All right, welcome to Chapter 8 in PTA 103, Therapeutic Techniques, aka the Modalities class. We're looking at Chapter 8 today, Superficial Cold and Heat. We're going to kind of break this up into two sections. We're going to go over the cryotherapy component first, and then you'll see the thermotherapy in a separate video. But let's get started here. We're going to kind of bypass these objectives and get right into the material. So let's talk about cryotherapy. Some of the superficial cooling, heating agents that we're going to talk about include the following here: cold packs and hot packs, paraffin wax, which we've seen in lab already. We don't have access to whirlpools, but we can definitely use those, as well as infrared lamps. Well, let's talk specifically about cryotherapy and the hemodynamic effects. So whenever we are applying a cold pack to a patient, the main goal is to reduce blood flow to that area to reduce inflammation, reduce edema. So when we do apply that cold pack, we're going to get this physiologic response of vasoconstriction, and the vasoconstriction can actually lead to about 40% reduction in blood flow to those specific areas. So that's pretty significant. Something else that we need to be aware of as clinicians is something called this hunting response. So what is the hunting response? Well, when we are exposed to cold for long periods of time, initially we're going to get this vasoconstriction, which is something that we're looking for a therapeutic effect. But after about 15 or 20 minutes, probably more so 20 minutes, we start to see this alternation between vasoconstriction and vasodilation. So this is, if you think about it, a way for the body, it's the body's own way of protecting tissues from potential cold-induced injuries, such as frostbite. Now, our body can only overcome so much. If you're stuck in a snowstorm outside, eventually, your body's not going to be able to keep up and continue to get blood flow to certain areas. It's going to actually shunt that blood to more proximal organs to kind of keep yourself alive. So it eventually will kind of hit the wall, if you will, and it won't be able to continue to send blood flow there. But it's really important for us to understand that as clinicians. So what is the clinical application of this? Well, we need to know exactly how long to apply a cold pack for, or educate our patients on the use of cold packs at home. Because if we're trying to reduce blood flow and we're trying to really take the benefits and reap the benefits of vasoconstriction, to see that decrease in inflammation, decrease in swelling, then we need to know exactly how long to use it for. So 15 to 20 minutes. Once you hit that 20-minute mark, you're going to want to take that off, because you're going to start to see this vasodilation, which is actually going to increase blood flow to the area, and that's something that we're not trying to accomplish with the application of a cold pack. So the hunting response is something that you need to be aware of, specifically to make your treatments more effective in the long run. Now we're going to look at the neuromuscular effects for cryotherapy. So we can see all these here. We're going to see decreased nerve conduction velocity, and that's especially true in those A delta fibers. So we talked about the different fiber types and the types of signals they transmit and how fast they transmit them. So when we apply these cryotherapy packs, different applications, such as ice massage, we're decreasing the nerve conduction velocity of those A delta fibers in particular. And remember, those A delta fibers are the ones that are responsible for that sharp pain sensation. Since we do have this decrease in nerve conduction velocity in those A delta fibers, that's going to increase our pain threshold. So if somebody comes in with a significant amount of pain, especially to touch, pressure, those kind of things, even with exercise, you apply this cold pack for 15 minutes, they're going to feel less sensitive to those same stimulus that you were giving previously. The next one down is altered muscle strength. So this is pretty interesting. There's a few different things that we can talk about, like quick icing, which you can kind of see at the very bottom of this slide. So after short introduction to cryotherapy type modalities, you actually see an increase in strength in the short term. But with prolonged cooling, like typically the ones that we're going to be using in our lab setting and in most of our clinical applications, you're going to see a decrease in that muscle strength because guess what? You're getting decreased nerve conduction velocity in not just the A delta fibers, but even in those alpha motor neurons as well. So short-term exposure can initially increase muscle strength due to increased alpha motor neuron excitability, but when you prolong that cooling effect, it's going to have the opposite results with that. The next one down is decreased spasticity. So again, we haven't gotten to our neuro section yet where we talk specifically about spasticity or any of the injuries that lead to spasticity. But just remember that these are with upper motor neurons. Spasticity is not the same as a muscle spasm. We're going to kind of distinguish the differences between those two in just a few weeks, so you'll be able to see the differences there. But we can decrease spasticity in our patients that do have something like a stroke or a TBI, spinal cord injury. And the reason that we can actually decrease this spasticity is because that cryotherapy application alters the muscle spindle and the GTO activity. So muscle spindles become less sensitive to stretch and the velocity at which we stretch that, which is good because remember that quick stretch is going to facilitate muscle action. And if we're trying to decrease spasticity, we want basically the opposite of that. So the muscle spindles become less sensitive to stretch. Then we get to the GTOs, and the application of cold actually increases GTO activity, which promotes muscle relaxation. So just remember that the muscle spindles are very sensitive to stretch and the velocity of that stretch. Typically, we use a quick stretch in our PNF techniques to help facilitate muscle action. So it's kind of a facilitation technique when we stimulate those muscle spindles. Whenever we are trying to inhibit muscle and get more length out of a muscle, typically we're going to try to stimulate those GTOs, those Golgi tendon organs. So anything that we talk about in the future related to PNF techniques, a quick stretch, we're going to get muscle spindle activity, increased contraction of the muscle. Whenever we provide prolonged tension to an area which stimulates those GTOs, prolonged tension is actually going to inhibit that muscle and actually cause it to lengthen and just relax. So I always give the example of you're at the gym and you're working through your very last set, you're very fatigued already, and you're doing your bicep curls and you almost get it up to the top, you're kind of in that mid-range phase, and then your muscle just gives out, right? You just drop that weight. That's your GTO saying, let go of the weight before you hurt yourself. You have that prolonged tension, you're stimulating it with that prolonged tension, with the resistance from the weight. Bang, you just can't do it anymore and you drop that weight. And that's a protective mechanism from those GTOs. But we can also use that to help increase length. The last thing here is facilitate muscle contraction via quick icing, 3 to 5 second intervals for about 5 minutes. So if you have the opposite of an upper motor neuron lesion and you have something like a peripheral nerve injury and the nerve is regenerating and you're trying to facilitate more muscle action, you can use like what we just talked about with a quick muscle or a quick stretch to the muscle, or you can use something like this quick icing technique to try to increase that alpha motor neuron excitability and get more muscle action out of that. This table just kind of shows what we mentioned earlier with pre-cooling strength. You can see on this timeline here, the red line shows the short cooling, less than 5 minutes, actually increases strength in the short term right away. When we do this long cooling, more than 15 minutes, you can kind of see that we have decreased strength output. But as we get back up to that 20 minutes and above, you can see that we tend to kind of regain that strength and even possibly exhibit more strength than the previous level of, the pre-cooling level. And that relates very well to that hunting response that we talked about earlier. So significant decrease in your blood flow to muscles, having that decreased nerve conduction velocity all leads to that decreased output by the muscles, but as soon as we get close to 20 minutes, right, it kind of flips, we vasodilate, and we get more blood flow to areas. You can kind of see that strength responding to that hunting response. Now let's talk about the metabolic effects of cryotherapy. So we're going to see a decrease in metabolic reactions. This decreases oxygen demand and energy consumption in cells, and it slows down the release of inflammatory mediators like histamines, which reduces swelling and inflammation in the area. So we talked a lot about how the application of cold packs decreases metabolic rates in reaction, and that's kind of some of how it actually functions and shows it with a physiologic effect in the body. It's also not recommended when you have delayed wound healing. So if we have something like delayed wound healing or an open wound or something like that, we want the metabolic rate to actually increase, right? In order to, produce more collagen fibers, produce, a lot of these other structural cells that are going to help heal the wound, heal the tissue. So it's not recommended for any kind of chronic type wound or diabetic ulcers if it's a chronic thing. So we want to actually maybe go the other direction with thermotherapy to increase that metabolic rate. So anything chronic related, it could be stuck in that phase of just like inflammation, delayed wound healing. We don't want to put ice on that. We want to actually do the opposite, increase our metabolic rate there. This one's also interesting, this very last one here. You can read that little slide. Cartilage degrading enzymes cease when temperatures reach 86 degrees. So anytime that we apply a cold pack or any type of cryotherapy to the area, that cryotherapy actually reduces activity of enzymes involved in inflammation and tissue breakdown, such as collagenase. So that's really important for decreasing the amount of damage in the area, right? We're trying to decrease that metabolic rate. We're trying to decrease the rate at which these enzymes are breaking down tissues, especially in the cartilage, because what we do know about cartilage is that it does not regenerate, right? We just can't get that back. If you have osteoarthritis, it's not like you wait a few months and then your knee is better. It's not going to heal on its own. The only possible thing to do is PRP injections. They're coming out with more things that you can do like that, or a joint replacement at some point. So really important that we stimulate those enzymes and we decrease their activity, after an acute injury or something along those lines. So what are some of the clinical indications for cryotherapy? If we see inflammation present, if we see edema or swelling present, if our patient has pain, those are all going to be for sure clinical indications that we would want to apply cryotherapy for. And remember that pain control can be either from decreased nerve conduction velocity in those A delta fibers, or we can actually maybe just decrease pain via the gate control theory, where we're giving the patient some kind of non-noxious stimulus to an area where they typically do feel pain, and that non-noxious stimulus closes the gate at that spinal cord level and doesn't allow that pain signal to reach the thalamus and the areas of the cortex. We can also, again, decrease spasticity in our patients that have upper motor neuron lesions, or we can use a quick icing to help facilitate muscle action. This is going to be a really important slide for you all here to know these contraindications and precautions. So let's go over these really quickly here. So if somebody has circulatory compromise or PVD, peripheral vascular disease, we are not going to want to apply cold therapy to that patient. They already have decreased, let's say their arteries are kind of blocked a little bit. They have poor circulation. They're not getting a lot of blood flow to those distal extremities in the feet, like a patient with diabetic neuropathy may have, or just diabetes in general. And then you apply a cold pack to the area. We're inducing vasoconstriction. It narrows those arteries even more, And now we're not getting any blood flow and we're not getting any oxygen to those areas. So that's something that we definitely want to look out for. We do not want to apply cold pack to a patient with PVD. Next one down is cardiac dysfunction or angina pectoris. So we haven't talked a lot about the cardiac dysfunctions, pathologies, or anything like that. But when we hear the term angina pectoris, typically what happens is a vasospasm essentially of those arteries that feed the heart. So again, if we're applying a cold pack to this patient, that could cause further vasoconstriction, which may increase the cardiac workload and exacerbate their symptoms. The patient that has angina pectoris is going to feel a lot of chest pain, heavy pressure, almost like an elephant is sitting on their chest. And we'll talk about the different types of angina pectoris, but we want to be really, really cautious, at least if you're going to use cryotherapy with this patient. Impaired sensation is another one that we want to look out for. If they can't feel how cold the sensation is from the cold pack application, then they may not be able to feel the effects of tissue injury, such as frostbite. So have we applied cold packs to a patient that has impaired sensation in the past? Yes, but you need to really, really be careful and monitor, probably more so than you would with a patient that has regular sensation. Next one down is over an open wound. So obviously we kind of talked about this earlier. This can delay healing by reducing metabolic activity. We do not want to apply any type of cold pack over an open wound or a chronic wound for that matter, because we are not trying to decrease metabolic rate. We're trying to increase metabolic rate to help heal that wound. We also don't want to put a cold pack over an area where there are regenerating peripheral nerves. Peripheral nerves regenerate at a very slow rate already. So applying a cold pack to the area, decreasing metabolic rate, we're just going to slow that process down, and we could potentially cause more injury to that area with the application of a cold pack. Cold urticaria. Urticaria, fancy word for hives or some type of allergic reaction. So whenever we are performing our patient interview, we need to ask them if they've ever experienced any type of allergic reaction to cold application. Have you ever had a rash that's raised off your skin that looks like wheels or circular in nature? We also want to assess for that after the application of the cold pack. So not only are we asking the patient if they've experienced this in the past, but we're also going to assess for that during our treatment, after our treatment, just to ensure that we don't have any adverse reactions. The next two are cryoglobulinemia and hemoglobinuria. So let's kind of talk about these ones for just a second. Cryoglobulinemia, if you look at the very end of this word, emia, you should know that that's related to something with the blood. So what cryoglobulinemia is an aggregation of certain proteins in the blood, and they coagulate and they kind of just form this almost what looks like a clot. So again, think about what we're doing here. We have cold pack application, which is already vasoconstricting, and then we have a patient that has this disorder where when they do experience cold or when cold's applied to them, these proteins in their blood tend to coagulate and almost form a separate clot. So two factors there that are going to lead to decreased blood flow to certain areas in the body. Let's talk about hemoglobinuria. So again, if you look at the very end of this word, urea is something related to urine. So what this is that when a patient is exposed to cold, our red blood cells are broken down and the hemoglobin is actually discarded through our urine. So this would kind of present with a dark colored urine, so almost cola colored, if you will. And sometimes people even assume that it's just red and blood in their urine. So you can ask your patient if they've ever experienced any dark colored urine after the exposure to cold for hemoglobinuria. And for the cryoglobulinemia, this is more prevalent in your patients that have hepatitis C or any type of blood kind of pathology. So you can ask your patient if they have hepatitis C. And if they say yes, then there's a higher likelihood that they might experience this cryoglobulinemia. The last one down at the bottom, Raynaud's disease. This is something that you'd be able to assess in the clinical setting with the application of cold. So what this really looks like is that when you apply cold, let's say to the forearm, like a cold pack, after a certain amount of time, your patient's hands are going to, or their fingertips are going to turn blue. That should be concerning to you from the very beginning. But as soon as you remove that cold, they'll turn to a very white color, so almost like they're blanched. And then at the very end, they're going to get red and they're going to start tingling and they're going to have this decreased sensation in their fingertips. So you need to ask your patients if they have ever been diagnosed with Raynaud's disease. Something that you may also see it with is systemic lupus. So you can also ask them if they have a past medical history of that as well, because it tends to run kind of hand in hand with that diagnosis. Okay, and some of the adverse effects of cryotherapy, a lot of what we've already talked about over these past few slides. Tissue damage or necrosis with prolonged exposure to cold is something that we need to look out for and we need to educate our patients on. We can have nerve damage, which is why we don't want to place a cold pack over regenerating nerves. We can experience, or your patient can experience, the urticaria or those hives. You may see an increase in blood pressure via the vasoconstriction, so be cautious with your patients that have hypertension. We might see delayed healing or feeling of stiffness. So if you do see open wounds in the area and maybe they're chronic in nature, you're going to definitely not put a cold pack or any type of cryotherapy over that area. Or if the patient already feels stiff, then you're not going to apply a cold pack to that person either. You still can get skin burns and blisters with ice, which is why it's so important to check the skin after the application every 5 minutes. You know, it may seem a little over the top to do that every 5 minutes, but the very first instant that you have where someone burns themselves, you need to make sure that all of your bases are covered, essentially. Okay, CYA, you want to make sure that you're doing everything you can to limit your own liability. Check the skin, look for skin burns, look for blisters. And the last thing that we need to think about over on this slide is this cold intolerance, which should be a contraindication. So the things that you need to be aware of, the diagnoses that you need to be aware of, would be hypertension for obvious reasons that we've talked about already. Sickle cell anemia. You'll learn more about sickle cell anemia in your fundamentals of disease class, but these sickle cell or these sickle-shaped red blood cells can lead to more clots in the arterioles and lead to decreased oxygen delivery to certain tissues. So again, if we are vasoconstricting, that already gives those sickle-shaped cells more of a reason to coagulate and experience decreased blood flow to those areas. Fibromyalgia is something else that you might want to consider not applying cold packs to or any type of cryotherapy. Typically, these people with fibromyalgia have muscle stiffness, joint stiffness already, so the application of cold may worsen that muscle stiffness and discomfort in those joints. So maybe something more like a hot pack would be better. Also, the last thing that we have on this slide is our hypothyroidism. You've already learned from your fundamentals of disease class what hypothyroidism is and what it leads to, right? So hypothyroidism, those patients are typically going to experience a decreased metabolic rate. So we don't want to slow that metabolic rate down even further by introducing a cold pack to that person. Here are a few different types of cryotherapy. We've used these cold packs up on the top left corner in the lab setting. We've used the ice cup on the right side. We talked about the vapocoolant spray down on the bottom right. And then something that you may or may not see in clinic, it's typically more common in outpatient clinics, is something called the Game Ready machine. So you can see the sleeve that is wrapped around this patient's leg and knee. There's a hose connected to it, and that hose connects to that little basin that you see in the back left corner of that image. And that basin is filled with ice cold water. So what you can do is you can set a pressure, medium, high pressure, low pressure. You're going to wrap that that sleeve around their leg. You're going to plug everything in, set the pressure, and then hit start. And then what happens there is that basin empties and it pumps into that nice little hose and into the sleeve. And the sleeve has a network of little tubes essentially that the water can flow through, and provides that cryotherapy with some compression as well. So when we talk about rest, ice, compression, elevation, the Game Ready does two of those, right? It does ice and compression, which is a really good feature. Probably best to elevate the leg if that person was experiencing inflammation or swelling, but regardless, you're getting two of them out of the way. I hope this is helpful. On the next video, we'll talk about the thermotherapy, indications, neuromuscular effects, metabolic rates, contraindications. I hope this was very helpful. Always feel free to reach out to me if you have any other questions. Thank you.